we have to study always the ocular surface, corneal epithelium, clinical interpretation to know how to interpret the Pentacam. I'm going to highlight the importance of astigmatism, angle kappa, wide to wide diameter, pupil, and corneal wavefront. Of course, I'm not going to talk about corneal wavefront in this session because the second session will be, which will be on the coming Thursday, it will be devoted to corneal wavefront. Moreover, I'm not going to talk about the ocular surface and corneal epithelium because the Pentacam cannot evaluate corneal surface and corneal epithelium. So starting with the clinical interpretation, before you interpret any Pentacam picture, we have to go through 6 steps. The first step is validation. We have to be sure that the capture is correct and it is not including factors of false findings. Then we have to know what is normal and what is abnormal based on evidence. Third, I'm going to talk very briefly about the indices and the softwares. Number 4, I'll show you how to exclude the sources of false findings, like false positives and false negatives. I'll highlight the importance of enantiomorphism. And finally, we will reach the practical subjective scoring system, which is the PS3. So starting with validation, how to validate the capture. We can validate the capture by going through 4 categories, actually. And any one of these categories that show abnormality, then we have to recapture. First, we have to use standardized settings. Then we have to check the quality specification. Then we have to compare pupillary coordinates between both eyes. And then we have to compare the manifest astigmatism, subjective astigmatism, with the topographical astigmatism. So regarding the standardized settings, first, the display should be in 9 mm, not in the 12 mm, as you see here. Why in 9 mm? Because we need to know if there are any extrapolated data. If in the 9 mm display, there are extrapolated data, such as black dots or missing areas, then we have to repeat the capture. If we are using the elevation map with the best fit sphere, we have to be sure that the diameter is in 8 mm, not in 9, not in 5. Why? Because if we are not using the 8 mm diameter, then all numbers will be wrong. This is an example. On the left, 10 mm, on the right, it is 5 mm for the same corneal surface. Then we have to look at the quality specification. It should be white, okay. However, this is misleading because in some cases, the Pentacam cannot catch the misalignment. This is a case of misalignment. The patient was looking downward. In spite of this, the quality specification was okay. White, okay. So we should not depend only on the QS that it should be white, okay. Then we have to compare the pupil center coordinates between both eyes. I have put this rule in order to exclude misalignment and differentiate misalignment from angle kappa, large angle kappa. You have to use X plus X. It should be less than 200 microns. Y minus Y, it should be less than 200 microns. I'm going to show you some examples. Now, this is a case of misalignment because Y minus Y is more than 200 microns. It is 0.26, so 260 microns. It means that the patient was, or there was, like vertical misalignment. This is the case of vertical misalignment. As you see here, huge Y minus Y, it was 760 microns because the patient was looking downward. This is a case of large angle kappa. The numbers of X in both eyes are large. In spite of this, X plus X is less than 200 microns and Y minus Y is less than 200 microns. So it is not the absolute number that we see, but it is the difference between both eyes. Regarding the astigmatism, you have to study the topographical astigmatism by using the total corneal refractive power at the 3 mm zone and then compare it with the manifest astigmatism. If you don't have an access to this map, then you can roughly deduct the astigmatism of the posterior surface from the astigmatism of the anterior surface if they are on the same direction as in this case. The anterior and posterior are vertical, steep vertical, so we have to deduct. But if one is opposite to the other, then we have to add. So let's assume that they were opposite to each other, then 2.2 plus 0.3, it should be 2.5. Now, we compare the topographical astigmatism with the manifest astigmatism. If there is more than one diopter in magnitude, difference in magnitude, or more than 10 degrees difference in axis, then we should not accept the capture. We have to repeat it, and we have to look why there is misalignment or disparity. Then we have to, this is a summary of the validation. We have to go through the 4 steps, and any of them, if it is abnormal or showing abnormal numbers, then we have to redo the capture. Then we go to normal versus abnormal. Regarding normal versus abnormal, I'm going to show you now the evidence-based, which are depending on references. For the KM, or the mean K, or the average K on the anterior corneal surface, the K reading should be less than 48. If it is more than 48 in the Pentacam, according to Holiday, or 47.2 in placebo-based devices, according to Rabinovich, then it is considered as abnormal. We come to the thinnest location. If the thinnest location is less than 470 microns, it is considered as abnormal, because less than 2.5% of normal population have less than 470 microns at the thinnest location. We come to the sagittal curvature map. We have to study 2 things in the sagittal curvature map: the inferior superior asymmetry and the skewed radial axis. So remember, 2 things to look at the map. Now, for the inferior superior asymmetry, you have to look at the what is called the topometry map in the Pentacam. It can show you the I minus S. And if it is more than 1.4 diopters, then it is considered as abnormal. We come to the skewed radial axis. If it is more than 21 degrees skewing between the superior and inferior segments of the bow tie, then it is considered abnormal, but the astigmatism should be at least 1.5 diopters in order to consider it as significant. So if there is more than 21 degrees, but the astigmatism, the topographical astigmatism, not the manifest, the topographical astigmatism is less than 1.5 diopters, then we can ignore this 21 and above. We come to the best fit sphere. Regarding the best fit sphere, if we are using the best fit sphere for the elevation maps, then we have to look at the thinnest location, the numbers looking corresponding to the thinnest location. And we have to follow this table for the cutoff values. Remember, for anterior 8, posterior 18, if the patient is myopic or emmetropic. And for the hyperopic or mixed astigmatism, the posterior 7, the anterior 7, and the posterior 28. So 8, 18, 7, 28. Just remember these cutoff values. And if we are using the best fit toric ellipsoid, then we have to follow what Jack Holliday recommends regarding the anterior surface. Any number within the central 5 millimeters should be less than plus 12, and any number on the posterior surface within the central 5 millimeters should be less than plus 15 microns. So all in plus. Then we come to the thickness profile, which describes the gradual increase of thickness starting from the thinnest location towards corneal periphery. So if there is a quick slope, which means that the captured cornea is increasing in thickness very quickly from the thinnest location to the periphery, this means that it is abnormal. And this is the average of increase. It should be less than 1.1. If it is more than 1.1, it is considered as abnormal. Then regarding the relative thickness map, which compares abnormality, let's say. Actually, every software or every device has many indices in order to simplify the classification of the cornea. I am totally against this. I'll show you why. Because the indices are objective evaluation, not subjective evaluation. Now, I gathered all indices used in all devices in the market, not only in the Pentacam, and these are the references for these indices. However, all of them, they describe either asymmetry, decentration, or deviation from normal population. But you have to remember that there is a gray zone. We cannot say that there is clear white and clear black. There is a suspect area. Moreover, the majority of these indices are not specific for keratoconus. Why? Because they describe corneal irregularity. So they are affected by factors of false findings. For example, dry eye, any irregularity of the cornea, scar, any opacity, any haze. So we cannot depend on those indices in diagnosis of ectatic corneal diseases. We come to the exclusion of false factors. As I mentioned now, why we cannot depend on the indices and the softwares in giving the diagnosis, because all of this list, the whole list, can affect the diagnosis. Using contact lenses, misalignment during taking the capture, large angle kappa, tear film disturbance, dryness or excess tears, corneal opacities and pathologies, previous corneal surgeries, early cataract, inadequate exposure to the camera, and pregnancy. This is the effect of the contact lens, and this is the effect of misalignment. This patient was about to be diagnosed as keratoconus, but it wasn't. There was only misalignment. Now, to show you or to highlight the misalignment effect or large angle kappa effect, let's imagine that this patient has symmetric bow tie. Okay, symmetric bow tie without skewed radial axis. Now, let's assume that this patient has large angle kappa, or he was looking, for example, to the right. Okay, then the symmetric bow tie will show skewed radial axis. Okay. On the other hand, sometimes we call that, of course, the previous slide, we call this false positive. So the patient doesn't have actual skewed radial axis, but because of misalignment or large angle kappa, the patient may show false positive. Now we come to this example. The patient actually has skewed radial axis, as we see, but because he was looking to the right, or maybe he has large angle kappa, the skewed radial axis will disappear and will show symmetric bow tie without skewed radial axis. And we call this false negative. Dry eye, of course, affects the K readings. It affects everything, measurement, everything. So we have to be sure that we have to treat ocular surface before we do any measurement to the patient. Excess tears as well. It may show false hotspot. Corneal opacities, as you see. We may think if we look at the corneal thickness, we can find very much focal thinning. And if we look at the posterior elevation, there is outbulging, which is true if we look at the OCT, but actually this is a scar. It is not keratoconus. So we have to be familiar with the patterns on the tomography, and we have to correlate it with a slit lamp. We cannot make a decision just by looking at the Pentacam. We have to correlate it with the slit lamp. Any corneal pathology may affect the tomography, such as Fuchs and Guttata, posterior polymorphous. Previous corneal surgeries, especially if they were complicated, such as striae, incomplete flap, buttonhole, all of that can affect. Inadequate exposure to the camera is one of the factors as well, because of, for example, prominent brows, prominent nasal bridge, small eyes, ptosis, sunken eyes, or head scars. Pregnancy is a main source of false positives because of refraction instability, because of increase in corneal curvature, because of increase in corneal thickness, and because of the biomechanical instability and increased risk of ectasia. So this is why we cannot make a decision if she is pregnant. We come to the enantiomorphism. What is enantiomorphism? Enantiomorphism actually it means that the right eye is a mirror to the left eye, and the left eye is a mirror to the right eye, as in this case. Right eye, if you compare the curvature map between both eyes, if you compare the anterior elevation map between both eyes, and so on, you will find like it is just like a mirror. Now, what's the importance of enantiomorphism? The importance is if you find enantiomorphism and skewed radial axis, you can ignore this skewed radial axis, and you can just take it off from your exclusion criteria. So there are two conditions where we can ignore the skewed radial axis: when there is enantiomorphism, and if the topographical astigmatism is less than 1.5 diopters. Finally, I come to my practical subjective scoring system. Actually, every time I talk about this, many people, they send me, what is your source? What are your sources? On what did you depend? Okay, great. This is why I intended to show you the references for every slide, every previous slide, the references that I depended on. Okay, great. Now, how I put this PS3, it is built for keratorefractive surgery, not for lens-based refractive surgery. It is based on all the previous data and in some aspects on my experience, okay? The aim of it is to be subjective rather than being objective, and to be systematic, so you cannot miss anything, to build a common sense. If you practice this PS3 day by day, picture by picture, then you will have a common sense. So from one look at the picture, you can say this is normal or abnormal. This is the aim of the PS3. In the PS3, I divided the abnormal, I splitted the abnormal into moderate risk and high risk. This is all what I did. Instead of keeping it as abnormal, I splitted it into moderate and high risk based on my experience, okay? But all are abnormal based on evidence-based. Now, I consider always the normal as low risk. So I cannot say that this is risk-free, okay? Any picture which doesn't have any risk factor is not risk-free, because refractive surgery is not risk-free. Okay, I actually put a system for the Pentacam, PS3 for the Pentacam, one for the Galilei, and one for the Cyrus and MS39. Today, I'm just going to show you the one related to the Pentacam. This is the table, and you can go through it in detail and see the exceptions, okay? So many exceptions from considering a high risk or considering a moderate risk. Okay, so if you want to read more about it, you can watch my videos or you can go to my 2 books. Okay, after I do the PS3, then I apply it to know whether the patient is okay for any type of laser-based refractive surgery or not. If there is no risk, or let's say low risk, so there is no moderate risk, no high risk, I can go for surface ablation, SMILE, or LASIK. If there is one moderate risk, then I will exclude LASIK. If there are 2 moderate risks or 1 high risk, I do nothing. I may think of lens-based refractive surgery, okay? But to apply this, remember, you have to validate the capture, okay? And you have to exclude factors of false findings. Otherwise, if you don't do this, you will find yourself excluding many patients. Many good candidates will be excluded while they are very good candidates. So you have to validate the capture, and you have to study both eyes, of course, and you have to exclude factors of false findings. Great. Now, what about Bellin-Ambrosio enhanced ectasia display? Actually, it is a very good map just to, let's say, make a warning. Okay, if it is green, then most probably it is okay. If it is red or yellow, astigmatism, posterior corneal surface astigmatism, into consideration in toric IOL calculation, then we will end up with overcorrection by average of 0.5 diopters if the corneal astigmatism is with the rule, and we may end up with undercorrection by about 0.3 diopters if the corneal astigmatism is against the rule. Now you may say, okay, come on, this is 0.3 or 0.5, it doesn't affect. Remember, this is the average, but the standard deviation means that you may end up with 1 diopter overcorrection or 1 diopter undercorrection, which has an effect if you are using premium IOL. It's very important to remember this. We come to the angle kappa. Angle kappa by the Pentacam is given by chord mu by holiday report. So remember, it can be given in the Pentacam by chord mu. Now, you know that it is roughly the distance between pupil center and visual axis. Now, if we are doing myopic laser profile, so usually by default, the excimer machines will centralize the profile with the pupil center, unless you shift it, okay? You do offset pupil. But if we are treating myopia, as you see, the whole area is treated, so the effect of coma is very, very small. But if we are treating hypertropia and we leave the machine do the job without shifting or without compensation kappa, we are going to create coma, remember. So this is why we have to consider angle kappa to avoid induction of coma. We come to the astigmatism. If we are treating high astigmatism, more than 1.5 diopters, and we are not taking into consideration angle kappa, we are going to create coma. For the premium IOL, if the premium IOL, of course, we have to, or let's say, when we implant the premium IOL, it will take its place within the bag, and it will follow the geometric center of the bag. So we cannot say that, okay, I'm going to push it nasally so that the center of the premium IOL will be on the visual axis. This is not correct, because it will take its place again to be centralized with the bag. So if angle kappa is large, then there will be a decenter in comparison with the visual axis of the premium lens. Therefore, the patient will suffer from dysphotopsia, post-operative dysphotopsia, especially if angle kappa is larger than 400 microns. And some let's say, physicians, some ophthalmologists may consider it if it is more than 500 microns. Actually, we have to be more conservative because we are dealing with premium lenses. So my cutoff value is 400 microns. Now we come to the white-to-white diameter. Why we have to consider it? Of course, for phakic IOLs, in order to achieve a volt between 300 microns to 600 microns to avoid induction of glaucoma or cataract. In addition, why we take the white-to-white diameter into consideration when we create the flap? Because if we are using the microkeratome, there is a table, for example, this is for Moria, regarding the size of the ring. Or if we are using the femtosecond, then we can customize the flap and the hinge size, all right? But if we are planning to centralize the laser profile, as I mentioned before, with the visual axis, then we have to, okay, so we are centralizing the laser profile. But at the same time, if we are not centralizing the flap with the visual axis, then there will be a complication. Why? Because if we remove the, if we are moving the profile, if we are moving the profile to be centralized with the visual axis, and the flap was not centered with the visual axis, then we are going to hit the hinge, and we may ablate out of the bed, which will cause irregularity and epithelial ingrowth. So we have to consider white to white. We have, in order to be sure that we can centralize the flap. Avoiding complications in femtosmile. This is the cut in the femtosmile. If the angle kappa is not significant, then the whole cut will be within the cornea. But if the angle kappa is somehow relatively high, then we are going to be near to the limbus. Now, if angle kappa is large, and because we are centralizing the cut within the visual axis, then we are going to cut through the limbus, and there will be very much difficulty in dissection. So by considering white to white, we can, let's say, make the cut just smaller to avoid intersection with the limbus. We come to the pupil shape, location, size, and shift. So as you see, it is not only pupil size. There are 4 components to study with the pupil. The first is pupil shape. We cannot go for refractive surgery for such patients. And regarding the pupil location, because it indicates angle kappa. If angle kappa is larger than 400 microns, then there is a contraindication for premium IOLs, as I mentioned before. And if we are planning for LASIK or PRK, let's say, then we have to centralize the profile. Pupil location, if the pupil is shifted as well, there is a risk of dysphotopsia if we are planning to premium IOLs. If the pupil size is very small or very large, it may be contraindication or asymmetric contraindication for refractive surgery. In addition, we have to study the pupil shift during the dynamic pupillometry. The dynamic pupillometry studies the behavior of the center of the pupil between the scotopic, photopic, and mesopic conditions of the pupil of illumination. So as you see, this is the red line gives how what is the range, or how wide the range of movement of the pupil center. Now, if the mesopic pupil is more than 7 millimeters, then we cannot go for any type of refractive surgery. If it is less than 2 millimeters or 6 millimeters, then we cannot implant premium IOLs. Why? Less than 2 millimeters, the premium IOLs are ineffective. And if it is more than 6 millimeters, then there will be dysphotopsia. If there was like shift more than 0.2 millimeters, then there is a risk of dysphotopsia if we are planning for premium IOLs. Now, I'll give you 2 examples of the Pentacam, how I study the Pentacam by applying all what I mentioned before. This is a case of a patient. This is the right eye, and this is the left eye. The patient is coming for refractive surgery. Great. So step number 1 is validation and exclusion of false findings. Step number 2 is application of PS3 on both eyes. So regarding validation, are the settings standard or not? They are standard. No extrapolation. We are using the 9 millimeter display. We are using the 8 millimeter diameter of the best fit sphere, and the quality specification is okay. This is the left eye as well. And I'm comparing both eyes in terms of pupil center coordinates. Actually, X plus X is minus 30 microns. Y minus Y is minus 40 microns. So there is no misalignment. That's okay. Then we go to a comparison of the manifest astigmatism with the topographical astigmatism. This is the refraction of the patient, and this is the topographical astigmatism. There is matching. There is no disparity. So it's fine. Great. Then I start studying the PS3 after exclusion of factors of false findings. Now, regarding the PS3, as you see, the KM is within the normal range. There is no inferior-superior asymmetry. We look at the thinnest location numbers, the elevation maps corresponding to the thinnest location, and we look at the pattern of the corneal thickness. Then we look at the thinnest location. The thinnest location is less than 500 microns. So this is a warning sign. Then we go to the elevation map with the best fit toric ellipsoid as Holiday recommends. As we see, none of the numbers is above 12 microns for the front or 15 microns for the back. So both are okay. Then we study the relative pachymetry map. the relative pachymetry map is okay because all numbers are less than, or let's say higher than in algebraic, -8, according to my PS3, okay? But according to Halliday, some numbers are suspicious. However, if we look at the thickness profile, it's fine. There is no quick slope, and the average is less than 1.2. This is the left eye. We do the same, KM, inferior superior asymmetry, elevation maps if we are using the best fit sphere, and the pattern of the thickness map, it is concentric. And then we look at the thinnest location, it is 469. So it is a warning sign. Then this is the elevation map using the toric ellipsoid. It is fine for the anterior, it is fine for the posterior. And we come to the relative pachymetry map. Don't look at colors, just look at numbers. These are hot colors, but they mean nothing because we can change the colors by changing the scale. So we look at the numbers. All numbers are more than -8 in algebraic, so they are fine. Then this is the left eye spatial profile, it's fine. And for the average, it is 1.1, which is less than 1.2. Okay, then this is the inter-eye asymmetry. We compare both eyes in terms of KM anterior, posterior, thinnest location, elevation anterior, and elevation posterior. It takes score 2, which is insignificant. So by application, applying this PS3 of the Pentacam, let's say that there is only thinnest location. Okay, the thinnest location is less than 470. So, sorry, this one should be here. Okay, great. So we have both eyes having less than 400 microns. And the left eye is borderline 469. So if we are planning to do the LASIK or something, then we can go as a one moderate risk in each eye. So we can go for surface ablation or SMILE. And we don't recommend doing LASIK. Now, this is another example. This is a patient with against the rule astigmatism, but with good corneal thickness. As you see, this is against the rule astigmatism. This is right eye. Okay, now, as you see, there is something abnormal in the left eye. Okay, this is the right eye against the rule, but it seems symmetric, but this is the left eye. Okay, let's study that. Validation. Settings are standardized. Okay, we are using the standard settings. No extrapolation of data. QS is okay. Even in the left eye, everything is okay. And regarding the XY coordinate comparison, both are less than 200 microns. So there is no misalignment. That's fine. We come to the magnitude and axis comparison of astigmatism between both eyes. There is no disparity. So we are okay. And then we come to the PS3. By the way, if you find any abnormality or if you suspect, just repeat the capture. Do not depend on the capture. So let's assume that after repeating the capture, the left eye stayed as it was. And this is for the right eye. For the right eye, 43 km, thinnest location. And we look at the inferior superior in the Pentacam, and it seems, just a second, because yeah. Can you see the number down within the red ellipse? Because I cannot see it because there is something hiding it. However, so everything seems fine. We come then to the elevation front in the toric ellipsoid. It is normal. We come to the posterior. It is normal. We come to the relative pachymetry map. It is normal. We come to the slope. It is normal. And Then we come to the left eye. As you see, there is an inferior steepening. If we look at the thinnest location on the elevation map, we can see on the posterior surface plus 22. On the posterior surface, the number is plus 22. But before we say it is normal or abnormal, we have to know whether the patient is myopic, emmetropic, mixed astigmatism, or hypermetropic, because we said the cutoff value for the posterior surface, if the patient is hypermetropic or mixed astigmatism, is 28. So if this patient is myopic, hypermetropic or mixed astigmatism, the posterior surface can be considered as normal. If myopic or emmetropic, then this is abnormal. This is why we have to correlate the pentacam with refraction as well. We can see that the pattern on the corneal thickness is not concentric. It is just like it's taking some shape of conic. And the thinnest location is less than 500 microns. And this is the inferior superior asymmetry, which is very high in the left eye. And regarding the relative thickness map, it shows, although there is like a pattern of focal thinning, but still within the normal. Surprisingly, the thickness profiles are normal, although we usually see quick slope in ectatic corneal diseases. The average here is 1.3, which is abnormal. So we come to the comparison between both eyes. There is disparity or difference in the 4 or the 5 in the 5 parameters. So 5 out of 5. And this is the application of the PS3. So for sure, we are not going to touch the cornea because this is an ectatic corneal disease, not in one eye, but in both eyes. We cannot say that one eye is normal while the other one is ectatic. Hereby, I go to some highlights about ectatic corneal diseases, how to define ectatic corneal diseases. Just keep it in mind, whenever you find abnormal anterior curvature map and abnormal posterior elevation map, this is keratoconus, all right? And regardless of the thickness map, because in some cases we find thick keratoconus and thin normal cornea. We come to pellucid marginal degeneration. We find crab claw on the anterior curvature map, and we find the bell shape on the thickness map. This is a hallmark. The bell shape is the hallmark of pellucid marginal degeneration. As you see, this is the bell shape corresponding to the thin strip in the inferior cornea. This is pellucid marginal degeneration with shine flug on the top and OCT on the bottom. This is PLK, which is pellucid-like keratoconus. We find crab claw on the anterior curvature map, but there is no bell shape on the thickness map. This is keratoglobus, thinning all over the cornea, and steepness all over the cornea. Steepness and thinning. What about form frost keratoconus and keratoconus? And keratoconus suspect. If one eye is showing abnormality and the other eye is keratoconic, we call this form frost keratoconus. Like in this case, the one on the left is keratoconus. The one on the right, there is only abnormality on the anterior curvature map. Other maps are normal, okay? Regardless of the thickness, we said. So the right eye is considered as form frost keratoconus. Keratoconus suspect when we have abnormal anterior curvature in one eye or both eyes, but there is no keratoconus in any of the eyes, okay? This is posterior keratoconus when we find everything is fine, but there is posterior bulging on the posterior corneal surface. Of course, we cannot say that this is progressive and needs cross-linking because we need to document progression. Okay, this is the second eye, the right eye. This is the left, and this is the right eye. Progression criteria. How do we document progression of ectatic corneal diseases? If you have Bellin ABCD keratoconus staging, then you have to use it because it is the best. And if you don't have it, then to document progression, for example, over 3 months, then you have to take 3 captures per visit, and you compare the medians of these 3 captures between the three visits. All right. ABCD keratoconus staging is much more accurate, but if you don't have it, then you have to depend on these 2 criteria, putting in mind same observer, same technician taking their captures, and take 3 captures per visit. Do not depend on only 1 capture. This is the Bellen ABCD. It classifies the cornea, whether it is less than 1, more, and so on. And it can monitor whether it changes, it jumps from 1 to 2 or 3 or 4, which means progression. Okay. This is the way, the other way. For example, this is first visit and second visit. The first visit is in the middle, the second visit on the left, and on the right is the comparison. There is 20 microns thinning and 1.9 diopters of increase in Kmax. Now we come to the last thing, which is observation after cross-linking, because this is where many physicians may make mistakes, let's say. As you see here, during the first 3 months after cross-linking, the K readings will jump up, normally 2 to 3 diopters. Then within the second 3 months, they will go back to the baseline. All right. And then usually there will be a progressive flattening over 2 to 3 years, maybe, where the K readings will go down for additional 2 to 3 diopters. So remember this slope. Remember this illustration, let's say. Regarding the thickness after the cross-linking, during the first 3 months, there will be a loss of tissue because of dehydration, about 30 to 50 microns. Then there will be a gradual increase in thickness to reach the pre-op baseline within 1 year. All right. So if we gather these two together and look at the first 6 months, the criteria are very similar to the progression of ectatic corneal diseases. There is thinning and there is steepening. So do not judge if there is failure or not in the cross-linking during the first 6 months. In order to start monitoring the cornea, you have to start after 6 months. So you do the cross-linking, you wait 6 months, then you do the three captures, and then you start monitoring the eye. Okay, so during the first 6 months, you cannot say there is a failure of cross-linking, because the cross-linking will cause steepening and will cause thinning, the same 2 criteria of progression. What is the differential diagnosis of ectatic corneal diseases? Corneal warpage due to contact lenses, corneal scars, previous corneal surgeries, severe dry eye disease, and any ocular surface disease. This is why you have to be familiar with the patterns, and you have to correlate with the slit lamp, and you have to put in mind to exclude any false factors. For example, decentered zone after ablation. If you look at this, you may think that the steepening in the inferior temporal steepening in the right eye of the curvature map is an ectasia. Okay, while it is not. It is just decentered optical zone. This is post-hypermetropic treatment. This is not keratoconus, although it is showing like a cone. And this is after corneal graft. Irregularities, but it is not keratoconus. And what about this? What do you think? Some people may think this is inverted pellucid marginal degeneration. It is not. Actually, this patient has superior limbic keratoconjunctivitis. So there is a superior limbic pathology. So we have to be familiar with the patterns, and we have to correlate with the slit lamp. So to take home message, Both corneal surfaces must be evaluated. The more maps and profiles you study, the more complete the study. You have to use a systematic algorithm in order to put accurate diagnosis and treatment plan. You must study both eyes. You must exclude factors of false findings before you decide, okay? And any abnormality in the tomography indicates recapturing the cornea. Validate the capture before interpretation. Memorize the tomographical definitions of ectatic corneal diseases. Do not overestimate ectatic corneal diseases. Not every irregularity is an ectatic corneal disease and rush to cross-linking. This is what's happening, unfortunately. Any irregularity is diagnosed as keratoconus. The patient is convinced to go for cross-linking, otherwise he will lose vision, while it is not keratoconus. Any high astigmatism in the patient may show high numbers on the elevation maps, and without the basic knowledge, the physician may think that this is keratoconus and may convince the patient to go for cross-linking. This is what I am seeing. Okay, this is what I am seeing, unfortunately. Memorize the tomographical signs of progression of ectatic corneal diseases. Memorize the topographical changes after cross-linking. Correlate the findings with the clinical examination to exclude entities misdiagnosed as ectasia. Thank you very much. These are my 2 books. They are full of this information. What I gave was just like 5% of what is written in the book and what's going to be